Too late, okay. So Dave and I worked together in Hayden, what years?
'04 to '07. And
04 to '07 or so.
no, '09.
More than that.
In
'09.
'09.
It was '04 to '09.
Adam was there. But Dave's background, he'll probably tell you, massage therapy, EMG, all kinds of stuff. He's the first one I heard the name Bioperformance Institute from, so I have to give him credit. I kind of stole it from him.
I have it in writing from '07.
I have it trademarked.
Oh, good, good. I have it from before you trademarked it.
Anyway, so Dave's, he'll go through it, but where his, I say, his extreme expertise is understanding the neuromuscular system of our body. He's an expert at measuring the electrical activity through surface EMG, like an expert of experts. And then he also has an extreme manual therapy expertise and something he called motor point, which or still does, but which is kind of acupressure with assisted stretching, total body thing that I learned from him, but I just kind of course, dumbed it down and made it faster into PT practice. But he has a very extensive treatment that is unbelievably impactful. And so I think the further I get into understanding humans, we realize that we are largely just balls of electrical energy, honestly. 99.99 repeating percent of an atom is space, which tells you right there what we are made up of, and so we're just balls of energy. So he'll go in a little more detail on that, and then we'll learn a couple maybe takeaways.
Couple things, yeah, a couple of hacks. I always wondered about that term hack, as if you're sort of cheating, but it's not cheating it's like saying, oh, we gave him a hack, we gave him the combination to the safe. But how many things do we use when we treat the body where we go in and, we've got the gels and the electrical stuff and we got the heat and the cold and we've got frictions and all these various things. And then we go in with surgeries when they don't do what we tell them to do. All the while, somebody walks along and says, but it's 31, 27, 41 or whatever, and it opens. So it also, I was going to say that what does it mean when a speaker puts their watch down like that? It doesn't mean anything. But I do want to keep an eye on this because I want to be able to get through anything that I'm going to say before 7 o'clock because we want to leave 30 good minutes. If you're okay till 7:30, I want to leave 30 good minutes so that whatever it is that you choose out of your three wishes, whichever wish you choose to pursue tonight, we'll have plenty of time to do that. So I always love to start with just showing you something interesting. So this is a lady that I got to work with. That's okay. It's going to start when I hit the thing, I think, because that's the black screen. So in 2019, it was one of the last seminars, right before COVID hit. I was doing a lot of traveling and teaching, and this gal came to a class that I had. I was up near the Canadian border, and she came with a friend of mine who knows her. Let's see if this comes on. Is it not coming on? Okay, it's not. Okay, so we are going to use this thing to do something. Maybe, I bet it timed out, right? Yeah, just timed out. So give it a second to find this. Did you do anything to make this, to get it to the source? Right, okay, HDMI.
I think it was 3.
That's the one, yeah. Okay, so I just wanted you, there's a couple of entertaining things I want to start with because like I always do live EMG demos at the beginning of a course because there's nothing like having a colleague moving right in front of you. You've wondered about their body. Suddenly you're seeing all this information. And with EMG, I like to use the term, are you familiar with WYSIWYG? What you see is what you get. When you see electrical activity from muscles, you're just seeing what you're seeing. Nobody's making this up. We're seeing it all together. We're all on the same page. No one's coming in here to try to say, oh, look, here's what this means. I'm just coming in and saying, let's have a look at this and let's see what everybody thinks it is. And it's amazing how much practical sense you can draw out of something that seems like it's so complex. Anyway, so this lady, she was my model the first day that she came into this seminar. I want to see if this...
And I'm a 2014 Sochi Winter
you can see about her.
Competed in half-pipe snowboard for Canada. Snowboarding is a demanding sport which requires a high level of coordination, timing, and of course, muscle control. And like most sports people out there, we don't just snowboard. We do lots of other sports that require all of these attributes.
This is all her, by the way.
Keeping strong so that I can do whatever sport comes in front of me is very important. I've done lots of traditional training and my fair share of unorthodox training, which is sometimes the more interesting part. It has been an amazing adventure, and I've learned exercises that will stick with me for a long time.
That's my invention,
Because
that
my journey
cross-country
is not
ski
over
thing. So.
yet. I'm passionate about all the things I do, from snowboarding to skateboarding, mountain biking to foiling. And now I have a little buddy that I can share my love of all of these things with, which is so important to me. I know that you'll all agree that getting old sure ain't easy, but you can definitely bet that I'm gonna make it graceful.
Okay, so when she came to my seminar called Redefining the Core in 2019, she had a back problem. And when I did her first, I love the alternating hip extension activity. You'll see, can you see that all right from where you are? So if I hit play on this, I probably don't have a pointer that I can get, but if I use the cursor, you'll see this is left anterior deltoid, right anterior deltoid, left lumbar paraspinal, right lumbar paraspinal, left glute max, right glute max. It's the left hamstring and right hamstring, biceps femoris, so lateral hamstring. So if you watch as she does her leg raise, this was with pain, and you can see the limited motion in her hip extension. Obviously, her and firing patterns off, you look how there's her left glute max, here's her right glute max doesn't fire at all, her left glute max fires some, and you look at how much more her left hamstring has to work to make that extension happen, where the glute's not firing. There's just you see what I'm talking about. It's a very simple, straightforward thing. I'm not going into real deep analysis of this, but if I go to this activity, what she's doing here, we'll have a minute to go over this. It's a bilateral hip extension. So you can see her glutes have to eventually participate, don't they? Like we push the system long enough, they're going to start to do something. Hamstrings are very, very active. Paraspinals are very active. Doesn't look like anterior deltoids are doing very much at all. I typically have people do this exercise for 80 seconds. 80 seconds is plenty of time to see median frequency shift. You know, every muscle consists of fast and slow twitch fibers. It's the median frequency shift that indicates fatigue. And fatigue will be evident using EMG usually about 1/3 of the way toward when people will physically experience signs of fatigue. So you will see metabolic fatigue. We'll see the beginning of electrical changes. She asked me what the record was for this. And I told her I think it was around 123 seconds or something. And when we got to 123 seconds, I said, well, what are you doing? She said, well, I'm setting a new one. So she stayed for 155 seconds on this activity. I've since had a Navy SEAL beat it, but that's Navy SEALs. He also waterboards himself to relax. So that might give you an idea about, pain tolerance, pain thresholds. So in this activity, what I'm going to do real quick to show you what I love to spend my days doing, I'm going to go to the marker menu. I'm going to delete everything in there. I'm going to capture like from here through to here and set the markers, hit the frequency fatigue report, and what I want to show you here is that this should give us a pretty good look. Okay, so even though it didn't look like her deltoids were doing much, they were getting tired not doing much. They were holding on for dear life. Paraspinals were busy. What you're looking for here is you're looking for a slope like this. So which muscle is dying the most? The worst death here in her activity. It's second from the bottom is the left hamstring. It's the first muscle to fatigue, and it fatigues the most. And do you notice above that, left and right glute max, are they getting tired? No. I've got 150 cases I can show you where this happens and the glutes are fine. And what do we always see clinically? Something wrong with the glutes. The glutes don't fire, the glutes don't want to fire, glutes are just, it's always a glute thing, and so we target glutes all the while this this is happening. And so what I wanted to show you is that so what I did is all we did is we gave her the 90-90 exercise. You're familiar with the PRI 90? How many of you are familiar with that? Because some might not be. Okay, so there's an exercise that we learned from Postural Restoration Institute many years ago. You're probably there, Adam. Were you there for that training? Yeah. Was it right around then? What it does is well, I can explain why it works. Anyway, this was approximately 10 minutes later, and you see how the range of motion, her glutes are firing fine, hamstring, glute activation. It's a very nice bounce. This is about a world-class athlete looking pattern. This is what you should see. This is what we didn't see when she walked in. And all we did is gave her one exercise that reassociated the left hamstring with the right hip flexor. It's a neuromuscular re-education exercise that reassociates left hamstring with right hip flexor. And she basically, her back pain was gone, her motion, it was a real wonderful thing to see. So I want to show you a different case real quick here, which is, so here is, this guy is a collegiate basketball player, injured. He's been to over 100 practitioners to try to resolve his back pain. He couldn't step down off a curb without searing back pain through his body. So this is his prone alternating hip extension. So do you notice a difference between this is his left leg going up? Do you see much for glute and hamstrings operating there? Hardly anything, right? Ton of stuff on the right side. So I want to show you that. Then show you he did a golfer's pickup. When you see this, you're going to get a kick out of this. So here he's going to be loading on his left leg and doing his golfer pickup as best he can. He's going to do 3 reps of that, standing on his left leg.
What's the green line?
The green one's at the top.
No, down a ways. Left.
That's his glute max left.
So there's nothing
Okay.
happening in his glute.
Right, nothing happening in his glute or anything. Okay, now watch what he does. Now he loads on the right leg, and he does a golfer's pickup. Doesn't this look a little odd to you? Like, you see this kind of thing. I had a Pilates instructor in the gym with me watching this evaluation, and she could not leave this guy alone. She wanted to do everything she possibly could to get him to fire his left side glute and hamstring. He was so flared up and messed up at the end of this because I let her sort of have at him a little bit. This was her attempt to get his hamstring and glute to fire. So take a look at what she makes him do here. I mean, those of you who know Pilates know probably what she's going to do. This is him. This is what hamstring and glute activation he gets doing this exercise. Practically nothing. So this is absolutely, it's the most extreme version of the pattern that we're going to talk about tonight that I've really ever seen.
His paraspinals are going bonkers.
Just bonkers, yep. So, and this was, I think I got a bridge with him too. Yeah, here's a bridge. You know, we do the bridge because we want to activate people's glutes and hamstrings, or people like to use the bridge. Well, what's happening here? He's doing a bridge. We're even coaching him, trying to get him to activate the muscles that are supposed to participate here. Clearly, that's not working. So what I want to show you is, here's his golfer pickup. Well, I'll show you the alternating hip extension. Notice the dates here. This was 9/4 of 2020, 10/5 of 2020. So 30 days later, basically. 30 days, not 10 minutes like with Katie, the snowboarder. So these are his golfer pickups. So here he is, loading on his left leg. Looks a little different, doesn't it? I don't want to I'll show you his alternating hip extension. It's about as nice as Katie's. And he didn't have his back pain anymore. 100 practitioners. He's gone all great lengths to do this. So what do you think we did with him? 90-90 exercise with biofeedback. So he took a home biofeedback unit. So he knew he was doing the 90-90 correctly. And he basically worked on that for a while, and that's the difference it made. So why the 90-90 works? I've seen people try to teach the 90-90 exercise. I've seen their patients leaving in tears because they couldn't learn it because it was just too difficult to execute. But there's a way to teach it that's really pretty straightforward and not painful and not doesn't create misery like that. Oh, here's a bridge as well. So this is, he's firing the way he needs to fire to create this motion. Now, any questions about that stuff right now? Because we're going to go on to just talking about compensation a little bit, and I'm going to explain the pattern that these. I'm actually going to. I don't know what I need to do. I think I just need to knock this out, because what I wanted to point out is that when we did a fatigue analysis on him, he had the same pattern everybody else has. The left hamstring fails first. So why does the left hamstring fail first, do you think? I'm going to put this out as a question because the title I gave for tonight's presentation was Earliest Observable Fatigue Onset Drives Predictable Patterns of Compensation. So if you know where the fatigue starts, everything else sort of builds around that. Does it make sense that would be the case? So if we could find that, and if we could make a change there, what would happen to the rest of the system? And is some of our, so you got to see those cases. We did an identical intervention, even though as far as a case study would go, who would think that those are the same, would require the same intervention? You look at something like that and you think, this guy needs all the king's horses and all the king's men, and she maybe needs a coach and a couple of things, maybe a little bit of triggering of certain things. It's true, she got better in 10 minutes, it took him 30 days, but isn't it interesting that it was the same core adjustment that each person had made that made them dysfunctional. So what is a compensation? Let's throw out a definition. Somebody want to give me a definition of what compensation is? Come on. See, that's what pizza does. What's that? Achieving function. Through an abnormal, that's a good one. I pulled it up through a wiki, whatever. I was sitting with my grandson the other day, and he wanted to know what wiki meant. And I said, well, there's WikiHow, and there's the Wikibus in Honolulu, and there's Wikipedia. And he was like, it means fast. So, smart kid. The definition, something that counterbalances or makes an undesirable or unwelcome state, or makes up for an undesirable or unwelcome state of affairs. So, it could be workers' compensation. You don't like what's going on, you get paid, you got to get paid. So, in human performance, we look at it as, and I kind of altered that. I said, changing, altering, or modifying how we move or stop moving the body or a body part in order to avoid pain and or complete necessary tasks. Is that pretty? I spent a lot of time trying to get all those words in a row. And nobody likes pain, but don't pain thresholds shift from person to person? People's tolerance is different. Who here has worked on both dancers and athletes? Who can handle more pain?
Usually, in my experience, dancers.
It's the dancers, right? Because the show must go on. There's just something about dancers where they've got this extra ability. I was working on two sisters in Austin. One was a dancer, one was a track athlete. And I remember the dancer mocking her sister. It's like, oh, she just can't take anything. And they were both, formidable in their fields, but quite humorous. So there are going to be compensations driven by pain. What I'm here to talk about tonight is is there going to be a difference between a compensation driven by pain and a compensation that's driven by something else? How many of you deal with insidious onset anything. You fill in the blank. Well, what is insidious onset? That's what I want to know. So we've got the idea of compensation. We've got the idea that people are doing it through pain avoidance or trying to execute things, working around an injury or some impairment or whatever. But what about this insidious onset thing? I worked up a definition for that too. First of all, the dictionary definition for insidious onset is, where did it go? Proceeding in a gradual, subtle way, but with harmful effects. So it sounds like it's a bad thing, but a bad thing in a small enough amount, doesn't it kind of look like normal? So for years and years, I've had people come to see me, and the first thing I tell them is, I don't look for problems, I look at what's normal. And most people don't consider that. Well, there's a Canadian songwriter named Bruce Cockburn wrote a song called "The Trouble with Normal Is It Always Gets Worse," and that's the nature of the insidious. They don't know. I don't know why. Have you had a patient come to you who says, "I don't know what I did"? Wouldn't it be great if you could just follow them around all day with a video camera and then play it on hyperspeed at the end of the day, and you're going to see them 15 times per minute doing this or something? You know, they'll have something that they do that you automatically notice that they never noticed because it's normal, it's natural. So it's not pathological. So my question is psychoneuromotor compensation consistent irrespective of a pathology? Like when people have this, when normal is getting rough or it's not going that well, and they're adjusting and they're adapting, is it consistent? Is there a consistent pattern to that, irrespective of the pathology? Does the level of intensity rise when pathologies are present? Maybe my question is the motor pattern adaptation that people create in response to an injury the same pattern that they create in response to just normal everyday stresses and strains? And that's what I found when, so I'd been using EMG for about 8 years when a company came along that wanted to develop a network where I was going to be analyzing EMG from multiple remote locations. And they financed the whole operation. They let me dream up protocols that remote sites could execute. They could submit data to me, and I would analyze that data and provide them with feedback that would help them in their decision making. So what did I not have? Didn't have the patient with me. I didn't have their history. I didn't have a pathology. I didn't have anything. All I had was the data. And you know what else we didn't have back then in 2000 and 2001 and 2002? We didn't have video. We didn't even have, there was no video along with the motion. All it was raw data of these protocols that I had them do. And I had to come up with those protocols, which muscles, which movements, but everyone was trained to do the same muscles and the same movements. And that's when I found out that to a great extent, the same compensation pattern was present in every case I saw. So that was shocking. And what was amazing too was when that company went to close down, and I took the box of data into their office and I said, so what do we do with this? And they said, we don't care about that. You can have that. So I took that with me. I thought it's like we've been gold mining and all they want is the gold mining equipment, and I get the gold. So I was able to go through, and I was actually presenting in Midtown Manhattan one time, and I said that what I've learned is that human beings are 24/7, always on, always learning, always adapting, decision-making, habit-building, pain-avoiding, comfort-seeking, and this woman stood up in the front row and said, lazy, good-for-nothing bums. And it's really true, isn't it? I mean, people are ultimately, we're conserving energy, we're seeking comfort, we're avoiding pain, we're doing these things. We're doing that, you're doing that right now. Just how you're sitting in your chair. You're avoiding the pain of sitting up straight, and you didn't eat vegetables over there. I saw that's like, we're going to live the way we want to live. So my question is, if I could show you a predictable set of adjustments that every human being would go through, I've got to warn you right now, you're not going to be able to unsee this once you see it. Once you know that this is how people adapt, you see, you got to, if you're going to stick your head in you got to get out of here. So, because would you be surprised to know that it involves fetal position to some extent, that there's some sort of primal reflex adjustment going on, some sort of self-protection voltage pattern that you would see at the earliest indications of it would be evident on EMG. Wait a minute, when somebody has pain, when somebody's, whether they have pain or not, human beings seem to want to move toward fetal position. So my question is, how well do you understand fetal position? Because right now, I've got probably being up here speaking, it's fear worse than death, isn't it, when you're public speaking? So probably my sympathetic tone elevates a little bit. Well, would you be surprised to know that we have, I like to say we have two nervous systems, not one. We have the self-defense nervous system, and we have the joyous dancing, adventurous spirit nervous system. And those two are always in this delicate balance. So which one do you think is getting a little more voltage in my case right now? It's probably the one that's scared to death, but I'm faking my way through this thing. So I like to use the saying. It's kind of the driver is always driving. And the idea that when the going gets tough, even the tough want their mommies. I don't care who they are. And I've actually done coaching of tennis players so that they can watch for signs of meltdown on their opponent. And you know what I teach them to watch for? Because I'm going to model or act out this pattern. Would you be surprised to know that if there's shortness in hip flexors, it doesn't make you go like this, except when you're old, maybe. It doesn't make you go like this because you wouldn't be touching the ground, so what happens? It creates a forward pelvis, which creates forward head. So right off the bat, you get the forward pelvis, forward head. That's fetal position walking. That's fetal position just up and around. So you've got more tone to the flexion chain. Now, if you pull the head forward and you pull the hips forward, there's the curiosity in this thing is that there's a twist to it. It's that because of the location of the heart above the diaphragm on the left and the liver below the diaphragm on the right, the diaphragm itself is not symmetrical. The fibers of the iliopsoas actually intermingle into the diaphragm. So every breath you take and every move you make, there is an asymmetry in your hip flexors, which means there's an asymmetry in your glute firing pattern, which means lumbopelvic symmetry is pretty much a myth. We're not going to have it. We're going to have some measure of lumbopelvic rotation, always. And I describe that we have a left load leg and a right lead leg as opposed to leg dominance or foot dominance. And what percentage of the population do you think right now is right hip flexor dominant? What percentage of the population do you think? Like if I tested on EMG, I know what the percentage is. Let me just give you a hint. It's the same percentage of people that have the heart on the left side. 100%. It's a lot of people, except for the freaky ones that I can't get my hands on them. They're maybe in Switzerland getting tested by experts. Anybody who's got flipped internal organs, I've got a standing order. If you can find somebody, send them to me. All expenses paid. I want to test them. I want to run through and see if anything is different here. But the fact is, there's a reason we live in a right-handed world. Did you know that at 8 weeks in utero, 85% of little babies go for their right thumb? 85%. By 12 years of age, 90% of human beings are right-hand dominant, not left-hand dominant. So what happens is we've got this core that, do you know that if you have a right hip flexor dominant core, in PRI they tell you there's a thing called a left AIC pattern, if you've heard of it, the left anterior interior chain pattern, which they traced through from an anterior rotated ilium on the left and an impinged shoulder on the right was part of their whole thing. And what I tracked through using EMG was that human beings are right hip flexor dominant and they're prone to an instability in the left rotator cuff. They're also prone to a left pterygoid, superior lateral pterygoid trigger point. They're also prone to plantar fasciitis, more in ones. There's a whole list of things. So I'm going to act out what this thing does because there's a twist to it. If you're right hip flexor dominant, it inhibits your glute max, which means when that person reaches their foot back, they turn out on the right. They don't turn out on the left. They turn out on the right. So you'll see their right foot turns out, their hips come forward, their head comes forward, their left shoulder goes up, their flexion chain starts up, their head goes out. and they're 90 years old. You see how that's a normal, you have to kind of shake it off when you do it, but that's a normal adaptation. If you got any questions about things that you will expect to find here once you know that pattern's at work. I was in airports today, thousands of people, and you look and see how many people have their right foot turned out. You lie a person on their back and watch their right foot flop out to the side. There will be some that don't, because there are plenty of other things that people do, but I used to teach a right hip flexor dominant pattern, a left hip flexor dominant pattern, a mixed pattern, and a reactive pattern. And after 20 more years of using EMG, I only teach a right hip flexor dominant pattern. And when I talked to the PRI guys, and I said, so you guys teach a left AIC pattern, and you teach a right AIC pattern, how many times do you see the right AIC pattern? And they said, oh, we never see that. Interesting. So the reason I'm telling you all this is I'm not making this up. How many of you know that Einstein was a violinist? I didn't know that until somebody told me that. So I thought you're going to learn something tonight if that's the only thing you learn, is that Einstein was a violinist. But he didn't like Beethoven. He liked Mozart. He didn't like Beethoven because he said, I can hear Beethoven in the music. So he didn't like that he could hear the composer, like the personality of the composer. There's something just in the way that this guy writes. It irked him or whatever. He could hear the presence of the composer. I don't want you to miss some of the real cool stuff about what's going on in the body because of, I'm just a messenger. I'm just showing you these things that I've seen. If I pull up, like, for example, did I turn this thing? Will it come up again? I think it will. Yeah, it will. So if I bring up, I have this other, I wish I could use Luke's data and his wife, because somebody that you guys know, because he's got exactly the same pattern. Left hamstring fatigues first. His wife, same thing. Left hamstring fatigues first. And when I was giving them their homework, including the 90-90 exercise and a couple of other things, they both thought it was just incredible because somebody finally told them why the things were happening in their bodies. And I thought, but this is why things are happening in everybody's bodies, which is almost, you know what an embarrassment of riches is? Like when you can see something that's so clear and present in everybody that you work with, you can't unsee it. And you start to have an ability to, like, I'm going to take you to my master database right now, which is, like, I have this starts with female 11 years old to 17. I'll bring this one, let me see which one was. One of them was that wasn't the one, was it this one? One of these, yeah, this is I just wanted to give you an idea of how easily, like this is a 15-year-old Olympic trainee figure skater in Detroit. So you can see you'll see the same patterns. What I mean by an embarrassment of riches is I have so many cases that are the same thing over and over and over and over again. And yet in each case, they don't know that. They think that there's her coach, actually her grandmother, paid for me to stay after. Her coach brought her in. We went through this whole evaluation. Turns out that she had had a fall, and she couldn't skate her long program anymore. She could only skate her short program, so she was in big trouble. So we found out we had her go through we had her do a lot of different movements and activities, a lot of biofeedback stuff. Turns out that she was not using her glutes to jump anymore. She was moving up into using paraspinals. She was afraid to fall. And she had lost the feedback with her glutes. So we rebooted her glutes, basically. And this was after we got her glutes rebooted. And she had to learn the 90-90 exercise. And she had to do some biofeedback and learn to get back into her lower body. Of course, I called her coach about a month later or something. I said, how's she doing? And she said, well, she's 15. So it's like, that's just a way of saying, yeah, well, we're working on all kinds of, who knows what else we were working on. But I thought that was a really interesting one, because we could go from that age all the way up to, how about somebody that's 55 to 64, somebody that like a bodybuilder. How about that? That'd be a really cool one. And we take, here's their alternating hip extension. I mean, this guy is a monster bodybuilder. You can see he's got pretty decent hamstring function, pretty decent glute function. And in his, he did a bilateral hip extension times 80 seconds. We did our marks. We shoot into a report. We get a frequency fatigue report. I haven't seen, this is like years ago. I don't even know what I'm going to see here. I'm just pulling this guy up. But I remember showing the class, does he have glute problems? Because he was having back issues and his glutes wouldn't fire, all this kind of stuff. What I wanted to point out to the class here was this guy does not have issues with his glutes. His glutes are champs. They're just cruising along like, you'll see it over and over and over again. The glutes are not the problem. There's something in the dynamic that's interrupting the voltage transmitting and communicating to where it needs to go. And he had hamstring failure. This one, if you look at, there was also, look at his lumbar paraspinals though. This was a guy where he had some serious back trouble. And everybody thought that it was because his glutes weren't firing, but it wasn't his glutes. It was crazed hamstrings, not capable of holding it up. I think the one case that I saw of a real anomaly was someone who had just had a cast off for a broken femur. That was somewhere I thought, okay, that didn't quite match what I expected. But that's what I mean by at what point does the pathology start to feed into this core adaptive pattern to the level where it might modify it and take it off of something that would be predictable. Yeah.
Which muscles fatigue first then? Left hamstring?
Left hamstring.
What happens in the shoulder?
Shoulder is one of my favorite ones to show. Here's left humeral flexion. Here's a bodybuilder guy. Let me see if I do a bilateral. And here's right hip humeral flexion. I don't have bilateral on him. What I was going to say is, so when you have a person just in a standing flexion like this, you'll very often see heightened activity through the left parascapular region. And what that indicates, I had to ask people a lot of times, you'll see more amplitude when a muscle has to work harder to create a motion because the team is not working well together. What you want to see is even distribution of voltage across a chain of muscles. And so what we would often see is like a person would raise the right arm, they'd raise the left arm, and they'd see more voltage, and they'd say, oh, they're left-handed. And we'd say, well, they're actually unstable in the left rotator cuff, so they work harder in the left anterior deltoid. So we go in and do a rotator cuff reboot on the left side, and their left shoulder drops, and their scapular glide improves, and their right hip extends more effectively. So you, in effect, can correct gait by doing a left rotator cuff activation. So that probably leads more into what you were wondering about. So I'm going to close this. I don't want to get... So I want to be able to, I want to know for sure that I explained this pattern in a way. I haven't graphed it out. I didn't have time to put together handouts so you could see this is exactly what to look for. That's something that I can work on. I wanted to tell you about it. I sort of want to leave you wondering if there's a way to dig deeper into this and to spend enough time on a way of addressing this. Like we'll go into the gym right away and we'll do the rotator cuff, or we'll do the TMJ, or we'll do the 90-90 exercise. Because when I asked how many did the 90-90, how many have done the 90-90? Adam, it's okay. So it's because 90-90 exercise could be, I mean, rotator cuff they're equally important, but 90-90 will give you, like, I'll give you an example. I've got a touring tennis player, played for A&M, #1 kid nationally when he was 16, played for A&M. The coaches just beat up the players. He was almost over tennis by the time he finished playing for A&M. And then he went out to play the pro tour and ended up with a severe sciatica thing. And he was about 1,100 in the world or something. And when he came to see me, they had something like 2 hours worth of exercises he was doing to try to just deal with this sciatica thing. I took him in the gym, taught him the 90-90 exercise, and he got up and he said, "What did you do? Wait, what did you do? It's gone." Like in months, he was 400 in the world. Like he just said, if I feel good, I play good. That's how it is. But all we did was reassociated his left hamstring with his right hip flexor, and it.
So for a simple way for you guys to prove it to yourself, like what I would recommend.
I can do the table test. Yeah, we can. Yeah, okay.
But when I'm seeing a patient, and I don't have the manual skills a lot of you do, but I passively flex their hip. I do internal, external rotation. I'll put them prone and do prone knee flexion. Guaranteed their right butt's going to lift more than their left. Their left leg will want to abduct when you do prone knee flexion, but their low back will hurt, right, when you do passive prone knee flexion, if they have a back problem.
Yeah.
So to me, that one is a great test to just, so what I would recommend you do is maybe you do prone knee flexion, tell me, okay, I just want to try something to see if it makes a difference or not. Think about where your pain is, do the 90-90, and see if it does anything or not. And there's a lot of different ways to get to inhibition. Like I learned the muscle energy. It's L5 flex, rotate left side, bend left.
Yeah,
You put it on left side lying and do it. Contract, relax, and you kind of get some of the same benefits.
I can probably show you 3 different ways to
This may be
abbreviate 90-90.
Your way is very benign. It's not
Yes,
going to hurt anybody.
exactly.
And then you can use it as a way just to test it and see if it does anything or not.
Yeah,
So
I think what we'll do, we'll go in the gym. I don't need to use this. This can just sit here. And I'm going to show you kind of what I do is that people will say, oh, that's a trick or something. It's like, this is the party trick portion of the thing where you just have a person lying supine and I just have them do leg raises and stuff, and you can see, you can prove the right hip flexor dominance on anybody. And you can also show the typical, rotated ilium, and then you can I'll show a hack for the 90-90. There's a way to do a thing that is, it almost creates the same effect as the 90-90, but it takes just seconds. It's super easy to do. But the 90-90 is the gold standard that you can do all the time. So we need to be, but do you want to head out there?
I think